And I was just arguing with them in the comments, and I just realized, yeah, I'm giving them these people traction. I was getting them more and more in my feed because Instagram kind of rewards hate watching. And I was like, yeah, this is not productive. I'm home, just we had like the lockdowns, and I'm just wasting my time. So I might as well just do a page where I kind of explain why I think this is nonsense.
Welcome to the N1 Experience, brought to you by N1 Education, the leader in fitness education. Today, we're going to talk about a lot of topics, probably focusing on the spine a little bit. But before we jump into that, why don't you tell everybody a little bit about what your background is and why we should care what you think on this topic?
I don't know if you should care about what I think, but yeah, again, my name's Alexis. I work as a physical therapist in Montreal, Canada. I got my degree, my bachelor's in rehabilitation at McGill, and then I did my master's in physio at McGill as well. And yeah, I work with like I'd say 50% gen pop and 50% just like high level athletes. But when I do that kind of remote because ironically, I'm known as someone online who like likes to critique a lot of the holistic stuff and just bad science, I'd say, or a lot of woo-woo stuff. But I work in a holistic clinic where I mostly work alone as a physio. I'm like self-employed, which yeah, kind of surprises a lot of people based on my again online persona. But yeah, that's pretty much who I am. I do a lot of like science commentary. I'd say I'm more like a science educator, but also do a lot of memes. So it can be confusing for people who encounter my page because I'll do a big review on I don't know, like 10 papers. And then the next one is just going to be a penis joke. And I think that gets a lot of people confused.
Yeah, so your handle is no BS physio,
Yeah.
right? And yeah, that's been my experiences. Is like I mostly know you through the memes, likely because those are the things that get the most traction and are the most likely to show up on people's feed rather than like the full breakdown.
And I was just arguing with them in the comments, and I just realized, yeah, I'm giving them these people traction. I was getting them more and more in my feed because Instagram kind of rewards hate watching. And I was like, yeah, this is not productive. I'm home. Just we had like the lockdowns, and I'm just wasting my time. So I might as well just do a page where I kind of explain why I think this is nonsense, and maybe bring people towards like what I think. First of all, why I think this is dumb, like with humor, and then maybe just once they're there, give them like, hey, this is like a scientific paper that explains why this is a dumb idea, why this is outdated. And it got people going because I feel like a lot of people, it's kind of unsaid in physio. A lot of people are trying to get evidence based. They're not getting rewarded at all. I'd say that it's probably the opposite experience. Like the better you do your job, like the quicker you get people better, the more you follow the evidence, the more you realize that a lot of the woo-woo stuff we come to the physio clinic for, like ultrasound or electrotherapy and all that, it's not that they don't work. It's just that overall, if you add them to just a solid, just like exercise program with education, there's very little benefit other than the filling the pockets of the clinic owners. And I do feel for the clinic owners because you got to make that buck. But I think the system is outdated, and if we actually treat it the way we should with minimal visits and education and self-management strategies for people who can do it, the need for physios would drastically be reduced and we could actually treat ethically. It's just not the reality right now. So yeah, that's kind of how I got started. Also, these people some of them try to sue me. They call my work and ask for me to get fired, and they were like, "Yeah, we're gonna sue you." So that got people going, I guess, because it's obviously very stupid. Like it's freedom of expression. It's very illegal for me to do it. Even in Canada, where we're more restrictive, I had to look like I double check. I actually went to law school, so I kind of knew the law, but I double check, and it's like I wasn't inciting genocide as far as I know, so I'm pretty much okay. And I wasn't inciting hate towards a visible minority, so I was also okay. Yeah.
Mhm. So I think like when it comes to the fear mongering stuff, I agree that like has really become popular, especially if in just I think negative or a negative marketing approach in general for fitness. Not just like, oh, you're going to get injured, but it's also like if you're not doing this, then you're going to get zero gains or whatever, all of
Yeah.
that stuff. Or here's the biggest three mistakes you're making. More and more of the YouTube titles and the captions, et cetera, I think are reflecting kind of these, you're missing out um approach or
Yeah.
I think once you get into more of the physio or biomechanical space, then there is like the injury risk. In the hypertrophy space, it's more like, oh, if you don't do this one exercise, then you're never going to grow and you're going to have small calves for the rest of your life or whatever it may be. Um, but as usual, there tends to be this kind of pendulum
Yeah.
effect, right? At least in certain groups, right? So there may like I think there's still plenty of people still pushing the fear side, but I think we've also seen some people kind of go the complete opposite direction and just be like, no, just throw caution to the wind. The body can deal with whatever you want, and like just load management. That's it, right? Or just
Yeah.
don't worry about anything. Like weight lifting is safe. Um, and I think in
Just
most
max out. Yeah.
cases, yeah. And I think in most cases, the truth lies somewhere in the middle. And, privately talking, you said that you've kind of had a little bit of a pendulum shift yourself on this. So let's go back to the very beginning of kind of when this conversation was hot, which I believe was something the discourse was around you and Squat You and I think Andrew Locke and
Yeah.
whatnot. Let's start with like give us a bit of like the history of like what the conversation was there, how it evolved, and then we'll walk through kind of to what your current position is.
Yeah. So I guess if I have to steelman their position, Squat You and Andrew Locke and all that, they're big, big fans of Miguel. It's almost the only scientist who they'll cite or like collaborators of Stuart McGill. This huge, he's to his credit, he's like the most published low back pain researcher or low back mechanics, I'd say is the more appropriate term because he's done very little research in people with low back pain. It's more with cadavers or human lifters and whatever. Um, yeah, so he's the most published in that space. So huge credit to him, and he's an extremely relevant and incredible like biomechanical researcher. So the place where we disagree, Miguel and I, like Squat You and I, or Andrew and I, is that it's when like we apply it to humans. That's really where my gripes start because if you look at the papers, they're very solid and how they're done, and they explain a lot of methodology, which is something a lot of physio papers don't do well. But then it's like, can we really extrapolate that to humans? And usually what they'll say to counter that is like, yeah, you can't expose someone, like try to provoke a back injury in someone that's not really ethical, right? A living human. And yeah, I agree. But there are prospective papers and retrospective papers that exist where we can draw other conclusions. And there's also human biomechanical models that are done. Like there's a lot of like the research by Von Arx, or I think believe it's like Dean in 1991, 1999, as early as that. He had like research showing that those biomechanical models, when they're extrapolated to humans, don't really work that well. Like it doesn't work. We're not like what's it called? The things you put baby in, like the science flute or whatever it's called.
Oh,
We're
like
not like in a vacuum,
yeah.
we're humans, we're stochastic, and movement is stochastic. Like you've heard of the dynamic system theory or whatever.
Hmm.
You know what that is? Yeah, it's like as soon as you have like more than two joints, it's impossible to replicate the same movement because it's stochastic. It's the same reason we can't predict the weather um more than like I think like 3 days in advance reliably. It's like chaos theory. So it's very complicated when there's not only the joints, there's the ligaments, there's the muscles firing, there's the person's experience with the movement and all that that's going to influence the nature of the lift and where the compressive stress happens. So it's very problematic to be like, hey, this functional spine unit done on like a porcine model does this, so therefore you should lift this way. I think that's like bigger gist of it. Everyone's heard of that, I think. Everyone, I think at this point who's interested in that space has heard about this thing. I think when it gets really interesting is when you get to like the why, because then you can have an opinion. I'm sure if we talk about this and I give all like the research that's involved, two people could have different conclusions. I'm okay with this. What I'm annoyed with is people who don't know and they're just like quoting Stuart McGill to me. It's like, yeah, I've probably read more of Stuart McGill than like 99% of people alive. Um, so it's like it's just yeah, we've moved beyond this. It's like how applicable it is where the conversation should be going, like in the gray zone.
So applicably, what was their position and where did yours differ?
Um, so for theirs is that basically you should never apply spinal flexion under load because it will create Disc herniation, disc damage, and pain. They also go for like even with light loads, they're like you probably should not. And that when you're lifting, you should, as much as possible, try to keep a neutral spine during lifting, because again, that is the cause of injury. They'll be very, I'd say, overly simplistic. They'll say like this is what I think. There's no debate scientifically that it's overly simplistic to say that this is what causes injury. So there's people that don't even lift that have disc hernias. If you look at the Battier and Wiedemann papers from 2009, the twin spine study, it's like the biggest twin study we have on this. Like disc structure and like spinal structure is about like 50% genetic.
Mhm.
And that's something that's what you have criticized him a lot for. You'll say like narrow shoes cause hallux valgus, so like bunions and foot deformities, which I agree. There are some papers, they're really bad papers though, like based on like Renaissance type papers, like literally cadavers of people before we had even the left and right shoes, like shoes that you would keep in your feet, and you needed someone else to get out of them. You would keep them for a day because they were made to ride horses and they were made of like hard leather. Like obviously not modern shoes. That's most of the research we have on this. Yeah, if you look at these people, they would have more deformities than people who were poor and did not wear shoes. Like that's obvious. The problem is like when you say this is the only reason, it's not your genetics. When we have specific papers showing, yeah, genetics play a big part as well. Um, so yeah, it's just the simplicity and the reductiveness, because then I think it scares people away from lifting. Because the reality is like everyone's spine is going to bend a little bit. Um, Even if it looks perfectly neutral, your spine is flexing, and most of the time it's flexing in the levels. Even the way they're advocating, it's flexing in the levels that will show damage in the studies.
Mhm.
So it's like their conclusion, if they're that okay, this biomechanical research is very, very applicable. Well, the conclusion should be, yeah, you should not, you should never lift. It should
Mhm.
be like you should lift with a neutral spine.
So let me know if I'm summarizing this just adequately, is
Yeah,
that kind of like the two main points, and for them not wanting to have that flexion is basically disc compression and the intervertebral shear, right?
yeah,
Is those are like the two parts of the model that they're like, oh, these are the two things that happen when we flex. And the we'll say the rebuttal to those with some of the other modelings has been we have plenty of examples in live humans of us going into these positions with loading where if we use that model, we should be seeing these injuries and they just don't have it. And that's kind of like the best counter argument of okay, that model not playing out in vivo is that when we apply that model to pretty much almost all lifters and even some relatively light loading activities, you know, the if we use those force calculations just to be like, oh, people should be getting injured here all of
yeah,
the time, and they're not. And then I think probably an incorrect, but the extreme example of that is everybody that likes to throw up the video of somebody hitting like their
Jefferson
PR
curl.
deadlift or something, right? And like, oh, look, they rounded their back. And
Yeah,
I think the mistake to take away from that is that the technique that somebody uses when they're literally setting their, world record, or PR for their life is the optimal way to train every
yeah,
repetition, right? And so I think that's the pendulum swinging too far in the other direction. So tell me a little bit about kind of what your approach or your, we'll say, recommendations were then, and then let's walk through kind of how you've changed and
yeah.
what are the reasonings behind that.
For me, it's different because I see mostly people with pain. So it would be, I do treat a lot of powerlifters. So when they come with pain, obviously, in most of them, I'll try to limit the type of flexing they're doing during a deadlift, just because it hurts. Like in most people, the majority of people flexing their spine, but extending their spine as well will hurt. It's just there's less extension movements in powerlifting or stuff like that. If they ask me like, should I do that forever? I would be like, no, but you should probably for technique reasons, right? But it depends because there's some people that are stronger with their spine a little bit flex. So I would go like, just don't freak out about it. If it like looks clearly okay, like it looks monstrous, it's probably not the best strategy because you're probably not going to be able to accumulate as much volume, right? Because it does seem to put more strain on the back, and you'll feel it if you deadlift with a more flex spine. Usually you feel it more in your back, not in a bad way, just like maybe you're more sore. Doesn't mean it's causing damage, but you're probably less able to recuperate. Like if you look at all these spinal models, there's no, that's another problem. So like it's really hard to see like the range that we actually use during lifting versus the one that we can avoid. So like let's say a squat is about 50% of full flexion, and then a deadlift is about 80% of your max. That's based on like the Eddington paper from 2015 on elite powerlifters. Um, the paper, those ranges are not used, or that's not what's compared in those papers. So it's not like, oh, you're going to do a neutral deadlift or a neutral squat. It's like we can't really use that research because again, they usually compare like neutral, like basically not moving the spine or just unracking the bar to actually doing a deadlift or way more, like 200% of spinal flexion max because they're cadavers, so they can bend the vertebra way more than we should be able to. So that's not very useful. Um, Kind of forgot my train of thought. But the point is, now my point is more like if we see that, I don't see that like the curve is going to be an S, right? If like extreme levels of flexions are worse, it's probably going to be quite similar. If we look at like a little bit of flexion. So to me, it's probably like a dose response, like more flexion puts more load on the back, but I don't think it's bad per se because if you displace the stress, the bar is still going up. So you know, if you have someone who has a lot of hip pain or FAI, I might advise more hip flexion for instance, more lumbar flexion. It's the same approach now more than I have to running, I'd say. So like if we look at people when they run, there doesn't seem to be one way to run that's more injurious than the other, but there are some ways that will provoke more injuries in specific spots. Right. So it doesn't affect total rate of injuries, but it does affect where you get injured. So like let's say you run more on your tiptoes, you're more likely to get an injury below the ankle, so foot or ankle. If you run more on your heels, you're more likely to get injured in your hip or knee. I believe that's like one of the Messier papers on this, and so it was a pretty large study. And so yeah, so I guess it's the same. So like if you have back pain, yeah, I'm probably going to advocate for a more neutral spine. Especially if you have a recurring injury of the back, like it keeps getting re-injured and you lift a lot, I'm probably going to be like, yeah, you can probably accumulate more volume if you keep your spine straighter. I'm still not in the camp where like I'm like, oh, you should never Jefferson curl, whatever. It is a pretty cool lift to if you want to be more flexible or if you just want to show off. And I have nothing against this. And I believe there's a lot of people who have weird spines where they can do this. I just think, again, like you say, it's in the middle. I think it's overly demonized. And I think also a lot of the videos that you see that people are cringing, they're like, yeah, you should never lift again. What we see is people with kyphosis, right? So their thoracic spine is very kyphotic, but their lumbar spine is relatively neutral. It's really, really hard to see the spine at the lumbar spine bending visually like reliably. It's very, very unreliable. Like if we talk about the neutral zone, I believe it's about 22 degrees before even if it looks completely neutral, like the paper by Laura Holder from 2015 and the Harjman paper, I believe from 2015 as well. They both show people like they're like literally their spine looks lordotic, so they look like they're an extension when they're lifting. But yet there's 22 degrees of flexion if you put reliable markers on it. So again, it's just not super reliable. So I believe we're like in the same center, but if we look at it politically, I believe you're a bit more center right. I'm a bit more center left, if that makes sense. But it's different because I treat a lot of people with pain and fear is a big predictor of like ongoing pain. And most of the people that have persistent pain, they've been told that advice first, if that makes sense. And if you look at people with chronic low back pain, they'll have very, very rigid spines the way they move. So that's a common finding. So people with low back, again, chronic low back pain, they'll always live very rigidly. And then you have approaches like CFT, like which are more behavioral approaches that are very successful and very economically successful, where encouraging them to do the movement the way that like feels injurious for them or they're afraid of, which is usually bending, that's very beneficial. So yeah, it's a lot of gray and it depends which population you're working. So in your case, where you work more with like performance goals, I believe yes, that is a good goal and a similarity in technique. I did a review on this as well. Like striving for a more consistent technique is predicted with better performance, right? If you're able to nail the lift the same way, you probably see the same for like soccer players, the way they kick the ball. So consistency is useful because you're using the same strategy, you're getting stronger in your specific muscles, But I also believe some degree of variability is useful because if you always do it the exact same way, when you're fatigued, you might risk injury because you've never been in that position. Do
Hmm.
I have strong papers on this? I do not. It would be very complicated to be tested. I believe someone in Belgium is doing a PhD on this. They're comparing like it's not the exact same thing, but they're comparing Jefferson curls to deadlift. Like that's the ultimate goal. Right now, they're just doing MRIs and Jefferson curls to see what happens. Um, but yeah, it's that's like my bias right now.
Hmm.
But again, I'm not. If a paper comes out and says I'm wrong, I'll change my mind pretty quickly. Yeah, sorry,
So let
long-winded answer.
let's kind of start with the person that doesn't have any issues. I'll
Yeah,
kind of give you kind of like my, we'll say, general guidelines in
yeah,
terms of looking at spinal flexion because you know, in a training environment, you have multiple things to consider. It's not
yeah,
just is this good or bad for, spinal
yeah,
flexion? Like, is this an injury risk? But we have like, well, what's the even the purpose of us doing the exercise in the first place? And,
yeah,
where's that relevant? Because, for instance, in a common occurrence now, especially like we'll say more of a bodybuilding population than say a powerlifting population because they're using way more machines and specialized exercises, is athletes can get into a state where their lower body strength has become disproportionate to their, we'll say, spinal erectors because
yeah,
they've been focusing so much more volume and maybe they've gone full mesos without doing any direct spinal loading but still continue to train their legs, and then they decide they're going to throw in deadlifts or RDLs or whatever it may be into the program, and now all of a sudden we have like that's become a weak link in the chain that otherwise wouldn't have been there if they would have just gotten to that point of strength doing exercises where the erectors were still a part of the equation and still being loaded. So when I'm looking at that, I'm looking at what do I need out of the exercise and not imposing a, we'll say, a fatigue or an injury risk where it's not necessary. Like I
yeah,
think the worst thing that you can do in terms of training decision is take unnecessary risks or introduce, fatigue that isn't actually beneficial towards the goal. Um,
yeah,
so when we're looking at like just the mechanics when people are doing hinges, a lot of times we're reinforcing neutral for one, just consistency,
yeah,
right? But two, looking at it is that if neutral is the goal, it gives us a larger buffer because the way I kind of see it is that if people are getting into more and more flexion, it's the closer we get to that end range, the less buffer they have if their technique does falter or they get out of position or they develop a little bit more momentum, etc. So one, I like just having that in there as the buffer so that basically extra flexion is kind of a safety net as needed if they would have it. And
yeah,
then also we just have the consistency of the lift.
yeah,
And then when it comes to the situation where we would need to strengthen the erectors directly, I still like motion rather than just depending on, trying to do a yielding isometric and things like, hinges and deadlifts. Um, but the question, like the place I think where people are still the most hesitant is going into that deep flexion, right? And then pulling out of it. Like a lot of people are fine doing hyperextension. Like they're, if you just have them do mild flexion and they'll hyperextend with load very comfortably. But I still feel like people are hesitant with that. And I think that is because it's just simply a neglected position. And so
yeah,
getting people into that, I find really useful, especially if we can incorporate some sort of unilateral loading, because one, we can get a little bit more range of motion, but also we can decrease the absolute load as well, right? And so that's kind of my approach is that, okay, if we're training the lower body, I want to have a buffer of range of motion in the spine so that if technique breaks down or there's some compensation that we have a buffer. But if I'm directly trying to do it, then I'm likely going to not do it in something where we have to also depend on this huge mass and a ton of momentum, and it's the
yeah,
leg drive that is working. And then I really like when it comes to, I mean, abs or pretty much everything that, would stereotypically be, associated with the core, right? But in terms of training the erectors, the QL, the obliques, the rectus, I really prefer unilateral work so that I can incorporate larger ranges of motion and sometimes a rotational, component. And they're not like turning it into a direct rotation
Yeah.
exercise, but actually getting into the rotation that opens up that space in the facets to allow us a little bit more range of motion and a little bit more specificity. And I find that that helps alleviate some of the hesitation people have in training and doing those motions. And I don't know if that's partly because it just makes the range of motion like feel a little bit more free and comfortable to go through, or if it's part of it is just simply that it's just a smaller magnitude of load, or a
Yeah.
combination of both. But that tends to be the ideal approach, like that I've kind of found over time.
Yeah. Honestly, I probably do exactly the same as you for deadlifts. The place where this becomes interesting is the squat. Because like if we mentioned that earlier, but if you look at the Van Dien review from 1999 or the Von Arx paper from 2021, what we see is that the way lifting with the neutral spine is taught. If you compare a squat to a stoop for lifting up a small box, the stoop where you kind of hunch over, there's less compression than there is with the squat, which is the way it's usually taught. That's the way I learned it in the gym. That's the way I learned it in French, it would be called like PDSB, the whatever, the how to move patients. Okay, the principles of that. And it's the opposite. And it's interesting because if you look at the review from Saraceni from 2020, it's a review of like advice on lifting at work, which they all have this thing, like lift with the straight spine, lift with your legs. They don't prevent injury. So is it because people are not applying it? I don't know. Is it because it's small loads and it becomes relevant at higher loads? I don't know. We don't have good data to support that, right? We only have the cadaver studies that use very large loads. Um, but yeah, so it's relevant for the squat because against the again for the deadlifts, I kind of agree with you. For the squat, I might be more forgiving for flexion because you're further away from your max. Your buffer's much larger, and sometimes to hit that depth, you do need to cheat with your back, if that makes sense, right? Especially if
Mhm.
someone has long femurs. And again, since that buffer is larger, I'd be way more comfortable being like, yeah, it's fine, especially if you start with the flexion and you just kind of stay there. Compared with the deadlifts, where again that buffer from that zone, that potential danger zone, because again we don't really know what happens at 100-degree flexion with that Jefferson curl. It's never really been tested. Even those cadaver papers, they always exceed it. Like they go to like 130, like ranges that you can't even reach without cutting the muscles. Uh, the closest that we have is the McGill paper. So the really interesting, that's one thing I changed my mind about recently. The McGill paper we did with Callahan in 2001. Um, Everyone thought that they would stay at like 30 to 35% of max flexion. And I think I believe it was in pigs that one. But I just know this because I know someone who studied under him, Greg Lehman, and he just corrected me recently. He's like, no, I talked to the guys who did that study, and apparently the way they tested the spine, which they did not write in the paper, is completely different that how everyone usually does it. So usually when you test neutral, the way you do that is you in cadaver papers, you you move the functional spine unit, so like the disembodied spine, and you go to the point in flexion where there's minimal resistance. So usually it's like 2 newtons meter, and then you go to flexion and then to the point where there's still minimal flexion. Once this ends and the flexion, the strain, the stress strain curve starts to go up, like there's more resistance to movement, you're out of the neutral zone. And then full range is calculated usually by where the stress strain curve stops being linear. So where there's a rapid increase in how much strain there is. So like basically where you feel like it won't budge unless you push really hard, if that makes sense, right? What they did in the McGill paper is they went until the fracture point under the lows they had pre-selected. So that's a way more aggressive way to do it. So they underestimated basically, they underreported, I'd say, the how much flexion was given. So they actually reached about 77%, which would be close to like I guess like a squat that looks really really odd because you have a lot of flexion, or a deadlift compared to a squat. So I'd say, and they show more damage in a more flex position. So I guess if you take that paper at face value, you'd say like, yeah, there's probably more stress on the back when you're doing a deadlift or when you're doing a very very stoop squat. Again, how relevant is it for humans? I don't know, but it would be make me think like yeah, if they can go to like 77%, I'm probably just going to take it more into account for the deadlift than I would with the squat, if that makes sense. Yeah.
Mhm.
long, yeah, kind of complex.
Interesting. Like my approach with the squat, since usually, I mean, we're never training the squat for the purpose of strengthening the low back or anything.
Yeah,
So we're usually just solving the problem biomechanically of just removing the need for the flexion to occur with either using heel elevation or bar placement
yeah,
or depth management, etc. And I mean, from an anecdote, I've had more people have, we'll say, back issues with squats than with any hinge type pulls.
okay,
And I think that's just kind of that's, once the nervous system gets involved and you're coordinating that movement, I think that's the thing is it's just the coordination demand of the flexion in a squat where basically you're having to conform in order to maintain your balance, right?
yeah,
Versus in a hinge or a deadlift, you're just essentially managing the load and it's more of
yeah,
a muscular solution than a kind of neurological and positional solution. So that's just kind of been my experience. And so for just the sake of consistency and focusing on training goal, we just remove the need to get there with some other biomechanical solution.
yeah,
Um, it's interesting, looking at we'll say, the degrees of flexion that some of these things use. But when you get outside the spine and we look at, exercises in the limbs or etc., oftentimes it's these exercises that actually have some of the highest joint compression or shear that we associate with the best training outcomes.
yeah, I agree.
And
Yeah,
that
of
hasn't,
course, yeah,
I don't know that many people consider that when they look at the spine.
yeah,
Or that when we consider that, like, okay, like if you just took somebody day one and you just put a huge load on them and threw them into this position, yeah, maybe that's a really bad idea. But
yeah,
what if we account for all of the adaptations that occur if we're progressing load and range of motion over time? And do we actually become more resilient to spinal flexion in those positions? Because actually there is we'll say, a greater muscular challenge. Like, for instance, the soreness that comes from getting into a flex spine during pulling, is that just part of the signal of what's happening when all of a sudden now we're loading the muscles at longer muscle lengths, right? Because
yeah,
especially acutely, and it's purely a biochemical thing that's causing that increased soreness, and it has nothing to do with there's been, any damage, especially like to the actual structural or connective tissues themselves, right?
yeah. It's a good point. I think there's two things about this. I think you treat more bodybuilders, right, than powerlifters.
Yes.
I think that's coming out. Yeah, because for me, it's like they need to squat or deadlift. A lot of the people
Mhm.
who I get referrals for. But also it's interesting because yeah, you mentioned like, usually the more stretched a muscle is, the more hypertrophy it will yield. But for the back, I don't think a lot of people are looking for hypertrophy of the back, right?
Mhm.
But they are for the
Well,
squat, you know?
in my,
That's
well,
except
I would
bodybuilders, maybe. Yeah.
say,
Yeah.
well, and I would say powerlifters too, right? Like
Yeah.
it's becoming like having thick and strong erectors, I think
Yeah.
in both populations is becoming, we'll say,
A flex.
more of a, yeah, more of a flex, but also like more of something that's looked at as a positive and part of an essential of the thing, right?
Yeah.
Like, I think it used to be like people were just so focused on like, oh, I just need to get my quads stronger
Yeah.
for my squats or whatever. But now I think people really start to appreciate, especially for longevity, the importance of having a, strong, trunk, right?
Yeah.
Both from an abdominal perspective and from a spinal erector perspective.
Yeah. And there's like, if we look like modifiable factors for low back pain, the main factors that are modifiable, besides like lifestyle, diet, stress, is being generally physically active. But one of them, I believe it's like a 20% prediction rate of low back pain episode is the strength of the erectors. And there are some other papers where people with chronic low back pain, there's fatty infiltration. I don't think that's going to change much with the strengthening. You're not going to change the fatty infiltration in the muscle. But just having general strength, like strong erectors, might be protective for low back. That's always what I tell people. It's like I don't have a strong paper to show this, but it might be generally helpful. And I think at least for the confidence aspect, being able to use your back regularly would be probably useful. And it's useful from like a functional perspective, I think. And if it applies to all the other muscles and all the other joints of having, more strength is generally protective, or I don't want to say stronger joints, but using it in a form of resistance training. So not necessarily extreme loads, but in a regular fashion, deliberate way, the way I'd say like soccer players do, is protective. So I always use the example of soccer players because they're healthy people that, their strength training looks somewhat easy to other strength athletes, but they're the ones where we see a lot of usefulness for injury prevention strategies. Like the FIFA 11 plus is it's fucking easy. Like as a soccer player, I'm considered like very, very strong, and I think I could probably deadlift like 400 pounds when I was training regularly. And I wasn't training the deadlifts like specifically, but like, that's ridiculous for a strength athlete, for a soccer player that's like considered super strong. And that's why I think they benefit, like the how much you benefit for strength training. It's like there's a diminishing returns at some point for injury prevention. I'm not talking about health necessarily, but it's just like just doing gentle resistance training with the directors, I think is a great idea. Is it useful for performance? Yeah, 100%. But is it like the stronger or your rectors are, the less likely you are to get injured with super heavy loads? I don't know. Probably. I don't think we have good papers to show that. If that at the time.
Yeah,
Yeah.
I I think it would be tough to take that conclusion to very trained individuals, right?
Hmm.
Of whether or not you've passed that. It's kind of like, the grip strength for longevity thing,
Yeah.
right? It's just like, okay, grip strength is just a sign that you're overall a physically active
There you
person,
go.
but you can't
Yeah.
extend your life by just starting to do finger curls, right? That's probably not going to happen. So probably a
Yeah.
similar thing here, where it's like if you're generally physically active and mobile,
Yeah.
and that's the reason that you have stronger erectors, that's probably good. But if you just decide that you're just going to start doing, Jefferson curls every day until you have, like, snails crawling out of your glutes, that doesn't necessarily mean that you're going to have bulletproof to your back. I don't know.
Exactly. Yeah, and I think that's another idea of people taking an idea to the extreme. If you look at health, that's what usually how I explain it to people. And the course I'm doing, a lot of it's like healthy aging, and you'll notice that there's a very, very strong tendency for a U curve. You see that for like upper airway infections. Like if you just generally exercise cardio regularly, but not to the extreme of like an elite athlete, you'll be healthier than both the sedentary and the elite athletes. You see that for running and NEOA. I believe it's the forgot the name of the paper, but it's like a huge meta-analysis. And basically, I think 50% less OA, knee OA, and hip OA if you basically do it at a recreational level, like running. But then the rate of OA goes up almost back to sedentary level when you're an elite, like ultra marathon or whatever. So I don't want to sound too Buddhist, but it's like the way of the middle seems to be helpful. And I'm not telling people you should not bodybuild or powerlift because being sedentary is way worse for so many other reasons. It's just I think we're often conflating performance with health, and you see that in a lot of people, and online. Like I think Liver King's a good example, or like all these dudes that are on. And I'm not against steroids. It's just a lot of people think that like looking fucking jacked, and people think that's healthy. When you have the veins popping out. And I'm not talking about people in the gym. A lot of people in the gym know, like, yeah, of course, if you're on gear, it's your choice and it's fine. It's probably beneficial psychologically for a lot of people, and you get more performance, which is great if that's something you want. But if your goal is to live longer and healthier, it might not be the best thing unless you have like a testosterone deficiency. But the general population is not aware. Like, I get so many people asking me, like, hey, you think this guy is natty? And it's like the guy who has taken the most drugs I've ever seen in my entire life. And they think like, oh yeah, he's so healthy. Like some people think Liver King's like super healthy. And like he made like how much was he making? Like 12 million a
It was
month.
insane. Yeah.
So like imagine what that's like a reflection of the average population. Like they have no clue. And that's why social media is so funny is you see these guys who are obviously not healthy, acting like they're super healthy because they do an ice bet, but they're also in like criminal levels of I don't know, GH.
Hmm.
I
Hmm.
don't know. Again, not demonizing drugs. Like, if you're an adult and you're making a healthy decision, go ahead. Like, do whatever. It's your body. It's just, I think the
Mm.
public's not aware of the risk or whatever.
Yeah. Tren will cure your low back pain. You heard it here first.
Exactly. Do
So,
you want the specific dosage or I'm just
yeah.
kidding.
Yeah, well, it's all about the site injections, right?
Here's my protocol.
Yeah.
Uh,
So I want to kind of go through kind of two theoretical case studies then
Yeah.
like when someone has back pain. So let's start with like the acute onset, okay, like pick something up, hurt it in the gym or whatever, instantly, boom, and then I have some sort of issue, right? What would like what are your immediate or what's your immediate advice in terms of like, all right, what are we doing for range of motion loading? Are we immobilizing? Are we doing, isometric loading? Are we going through light range stuff? Like, where does that process start?
So for acute low back pain, the main thing seems to be avoiding the principal trigger. We know that from a lot of papers. To accelerate recovery, I don't think there's much we can do, honestly. It's more about symptom control in the first days. So Hancock 2001 is a great paper on this. They compared chiropractic, just like spinal manipulation, to diclofenac, which is I think it's basically Voltaren. That's like the commercial name, to this placebo spinal manipulation, and all groups got better at the exact same rate. Like they did a curve, and it's exactly the same thing. So it doesn't mean like this doesn't feel good. If you talk to a lot of people, they'll feel like, oh, my back feels better or whatever. It could just be time, but if you look at other research, it has a small effect on pain. And what we do also in physio with exercise is also helpful. But to me, it's more like we're kickstarting something that's going to get better on its own. Because for acute low back pain, honestly, there's nothing much we can do that has like a vast effect on pain. Um, it's more about ensuring, to me, it's more about first reducing harm. Because a lot of people, if you don't treat them, they'll go see a doctor, which will give them, especially in the States, they'll give them like cortisone injections or push them for an MRI. And there's all like escalation basically is the worst thing you can do for acute low back pain, if there's no red flags, right? If you don't have like leg pain, if you don't have bowel problems, if you don't have what we call saddle anesthesia, the worst thing you can do is escalate. That's why I tell a lot of people like, yeah, just come to physio right away. Don't see the doctor or wait even like a week if you don't have those red flags. Because it is going to get better on its own. Like 50% of people within 2 weeks, they're back to work, and then I believe like the rate of recovery over 6 months is like close to like 90%, even if we do nothing, basically. So I just tell people like what it boils down to basically is staying generally active, try to do as much of the movement you can do with intolerance. So there's usually a movement that's super painful, try to avoid that one and just do the one that's tolerable. But it depends. There's also some people where they have something called like a directional preference. It is super overblown in the literature. Um, but yeah, but it's based on like the McKenzie approach. There's people like if you move them in a specific direction, they do much better than if you don't. Audrey Long has papers on this, and basically they showed that like they compared these people that respond to one specific direction rapidly, and then they're like, okay, do the opposite movement. These people did the worst, obviously. Then they compared to people that just did general movement in every direction, and to people that just did the movement in the direction that seemed to help quickly. So these people fall in something called a derangement, and they did way better, if that makes sense. That's not everyone, that's just some people. Again, those derangements we call. We don't really know how many there are. The McKenzie Institute says 50 to 60%. That's super overblown in my experience. And I've done a whole review on this, and it's like very, very nerdy physio. So I'm not going to get into the weeds of this, but point is there's some people that respond to a very specific approach, but most people just being generally active and avoiding the big trigger for a few days to weeks is probably the best thing you can do. But it's different. I think where we really shine in physio is like more like chronic low back pain.
Mhm. Yeah, and that's kind of where I wanted to go next is like, okay, so we have the acute onset, and then we have the person where like they've just been slowly like their back health has just been slowly degenerating over time, right? And it has now become
Yeah.
a long-term chronic issue, right? So how do you vary that? Like, how does that vary from the acute?
Yeah. For them, it's like the way I would explain it in very, very, very simplified terms is that the nervous system has been sensitized, if that makes sense. Like all these movements have been associated with pain, the predictive brain and whatever is just, okay, this is gonna hurt. So pain is created, even though the protective response is like its purpose has run its course and it's just like a leftover, almost like psychological trauma, if that makes sense. So these people they seem to respond to just first of all like general activity because a lot of it for chronic low back pain, what we see in the research that's emerging is that there's microinflammation. That's a big factor. Asaf Weizman has a lot of posts a lot of stuff on this on Twitter if you guys want to follow him. But point is, these people, that might be why they respond so well to just regular movement. So just being generally active. So Hayden in 2021 did a review of all the randomized control trials that we have, and it seems that basically everything works kind of the same. Like it works a little bit, except like Pilates like ranked slightly above the other things. But like, and then Mackenzie did like the approach I just mentioned. Mackenzie, the superiority or whatever goes away when you account for dosage. And the difference for Pilates was like so small. It's like honestly like zero point 0.1. So it's barely better than anything. So I think what we're seeing is that when you're doing something regularly at high dose, something that feels safe and is tolerable, your back seems to like it if you have chronic low back pain. It doesn't mean that like lifting loads at high rates is useful because again, if you account for dosage, it's almost exactly the same. Point is people need to be, it's gonna sound stupid, but people need to be active. The approach that I prone is something called CFT, cognitive functional therapy. So it's based on I want to say CBT, cognitive behavioral therapy. Yeah, it is. And they mixed it with physio. So it's basically what patient's belief, what do you feel about movement, what does this movement mean to you, whatever. And then we gradually expose you to the stuff that hurts. Or if you're someone that repeatedly exposes yourself to stuff that hurts, you kind of try to power through what we call like an endurance coper. We try to go the opposite, kind of restore like the middle, like have a healthy relationship with pain. Obviously, it doesn't work with everyone. There's people that have fibromyalgia and stuff like that that's really poorly understood, where beyond, again, kind of mitigating that neuroinflammation, there's not much we can do. And by mitigating, I mean medication, you know, psychological counsel where needed, and uh, just general exercise, especially cardio, because that has effects on this. There's not much we can do specifically in physio. But yeah, but again, to get back to CFT, the reason I like it is I was reviewing a paper on this recently, huge paper. And ironically, I forgot the name. But the point is, their approach, it was like super, it saves so much money. It was insane. I'll grab the numbers, but they did that in Australia with Peter. Damn, I'm forgetting every name today, but hang on. CFT cost analysis. Uh, I don't remember, and it's honestly it's really funny because I did a presentation on this last month. But
You
point is
can send
they
it to me and I can put it in the notes if you want.
yeah, but it was like thousands of dollars for every patient. Like
Hmm.
actually like ludicrous amounts of money. And the point is because it was just 6 visits over 6 months, I think, and there was like a booster visit if needed. A lot of people just took three because it's mainly like, hey, this will take a long time, so we'll give you self-management strategies. And this is how I treat like most patients, honestly, with most conditions. So it depends if it's an athlete and they need to come back like strong or stronger than they used to be, or if it's an ACL, we need to be very specific. With people with chronic low back pain, it's more about giving them self-management strategies. And when they do, again, you're getting the same results as you would with other approaches or better, but you're saving so much money. And that's one of the reasons I'm kind of annoyed with the physio space. And they all talk about, oh yeah, this approach gives you like a 0.005% better response or whatever. And it's just like, we're picking shitty studies apart and no one talks about the price. And it's just me as a patient. It's like, hey, do you want this intervention that works? Like that's thousands of dollars better? Do you want to do this like maybe shitty, like better approach? I'll give you like marginal gains, but you have to come 3 times a week. I will pick the other approach, like the cheaper one every time. And I think that's the case for most patients. And I think if most physios are being like willfully ignorant a lot of the time because it's not, they want to make money and I can't blame them. Yeah.
So, I think that's been a critique in the physio world, the chiropractic world, et cetera, is that the business model doesn't necessarily reflect the patient's best interest because the business model is, hey, the more sessions, the more dollars.
Yeah.
And the patients, it'd be realistically the fewest sessions, probably the most kind of self-intervention, you know, uh, approach. Interesting. So so we're looking at this acutely, or we're looking at this short term. Um, like the thing I took away the most is it's better to be mobile. Like that's really
Yeah.
the big thing there. Okay.
Yeah.
And it seems like you seem to be you seem to be pretty pessimistic on how big of a difference we can make in the recovery process other than just by being, just being mobile and likely the odds are general is going to be better for or is going to be adequate for most people. A small percentage of people, there's going to be maybe something specific
Yeah.
that would improve.
Yeah.
Like, you know.
I'll caveat it by saying, again, there's also I think it's important for a lot of people to at least especially if it's your first episode of low back pain to have an appointment just to rule out any red flags and just kind of teach you the whole spiel and reassure you. But there's also that I was talking more about prognosis, like how quick it's going to take. But for pain relief, if like the pain is unbearable, having a visit, we can kind of act like Tylenols, if that makes sense, right?
Okay.
It's like Tylenol won't make you heal quicker, cough syrup won't make you heal quicker, but it is more comfortable, right? I'll sometimes I'll have cough syrup sometimes when I have a cough, but I know it's not going to accelerate it. As long as people are okay with this. There's people who are like, yeah, I know it's going to pass, but I feel like shit. I just want you to me a massage or whatever, or I want you to, explore movement with me. I'm like, yeah, sure, absolutely. And if you have like leg symptoms, like neural symptoms, of course you should consult, I think.
Mhm.
Yeah. So that nuance.
So, do you think that if there are interventions that reduce people's pain, that I mean, even if we're just talking about daily motion, that wouldn't help, but indirectly because they would simply just be more active and more mobile in the absence of pain.
It's possible. Is it I don't think it's just because of the general exercise effect. Because usually, if you look back at McKenzie, the dosage that you're giving is so small. It's like literally like press ups or just touching your toes like 10 times every 2 hours. So it's like micro movement. You're not getting a sweat. You're not getting the mechanisms of exercise. So I think it goes beyond. There's probably like both a psychological effect and maybe effects on the nervous system where your nervous system is always guessing like, oh, this my tissue is in this state, so I need to protect it this way. I've had this insult, so I need to be this sensitive. So it's more like you're reassessing if that makes sense.
Hmm.
Right? A lot of people when I make them move, they'll be like, oh, this doesn't hurt. Like this is a very, very common response. And they're like surprised how far they can go. And one way that people can test this at home is if like even if you don't have pain, if you try to touch your toes and literally just like rub your nose and like we'll go woo, 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 woo. Like if you try to touch your toes again, you're gonna go much further just because the nervous system is always like careful the first time, if that makes sense. So
Hmm.
I think there's again, it's a mix of many variables. I don't think most of them are due to like the general effects of exercise. It's probably more just a mix of psychological and neural effects. Like neurophysiological is what we would call them in research. Yeah.
Yeah, I think a lot of people are very unaware how much just distracting the nervous system changes
Yeah.
function. And this is something that's like you see it all the time. You'll have maybe said influencer that's going to be like, oh, hey, I'm going to do this technique. And all of a sudden it's going to rapidly increase since they have somebody bend and touch their toes. And then,
Yeah.
whatever they do, they give them a wet willy or whatever,
Yeah.
and then have them reach down. And all of a sudden, oh, they have much more flexion. But in reality, if they would have just, walked, if they would have just reached down again, 15 seconds later, they would have had the exact same improvement, which I
Yeah.
find funny. Um,
Yeah.
I want to I want to ask you a little bit more about your thoughts on kind of chiropractic, because this is an area where, for me, my anecdote and the evidence kind of like pull apart from each other
Yeah.
because over the course of my personal training career, I've had two Kairos that were like magic for me in
Yeah.
terms of like I could get an amazing acute benefit and go from basically being, you know, dysfunctional back to just performing right away, like with like, not needing any time off or whatever, right? And literally going from acute pain to instant relief. But I've also had a fair share of experiences that, if anything, may be worse or no difference or whatnot. And those are, I would say, most of what I would say is considered standard chiropractic. I have found to not be effective, really.
Yeah.
Maybe there's a little placebo, in there sometimes. But then I've had a couple, well, that I would say a little bit more thoughtful docs that have had kind of a more like an individualized assessment. It's a totally different experience. I'm not
Yeah.
going to get super into it, but I do have like some instances where I've seen a very specific intervention give me an extremely acute relief, and then I've had others, not the other, and to the point where I would be very, very doubtful that there was that it was a psychological
Yeah.
benefit as much as it was like something physical. But I know that we don't have much confidence in the research behind, we'll say, standard chiropractic methods. So
Yeah.
I'm curious your thoughts are whether you basically think that we have very there's very we're very limited in terms of what we can accomplish in terms of acute interventions, or if maybe it's possible, but we simply just don't have research showing it.
Yeah. Like I'll just make it more precise. Like if we're talking about chiropractics, most people what they'll mean is spinal manipulation, like back cracking.
Hmm.
Um, it's not that there's no benefits. It's just if you look at that's the way research is usually conducted. You look at a general population, and there will be outliers in there, right? But if
Hmm.
you just look at population overall, for most cases, you'll see that spinal manipulation, it's not that it doesn't have an effect. It's just that it's usually a small effect. I believe it's like less than one out of 10 if you take everyone that has low back pain and you manipulate their backs. And there's the precise numbers on my page if people want to look. I did like a huge review on this. And there's also like 40% of people will get more soreness after. So the way I explain it is like for the vast majority of people, what it will be is a coin toss in either direction. Like it could be a little bit worse, could be a little bit better. And obviously, when we look at those, it's usually like a 95% confidence interval. So you might have fallen in that 5% that's a not liar. That's possible. It's just for me, the way I see my practice is I'm just taking a statistical guess, and that's not the most useful. That wouldn't be my first go. But it is possible. Like, there's Frederick Douglass was in the White House back, short after slaves like were made illegal. I don't even know if maybe slaves were still legal, but the point is, it's like, he was an outlier. So it doesn't mean it's impossible. It's just unlikely. You know what I mean? Uh, Probably not the best analogy, but yeah, the point is it is possible. Again, I think there's a lot of people who respond. There's some stuff that kind of predicts it. The main one seems to be the belief in it. So I'm not saying it's all in your head. Again, I think there's outliers, some people where there's weird stuff that happens. It's happened to me in the clinic as well, where I do something pops and they feel much better. I honestly, I tell them I have no clue what went on. But there is a big part for a lot of people where it's the ritual might bolster these effects of like, okay, this guy knows what he's doing. So you have higher belief because that's like for all interventions, including physiotherapy, the belief in the intervention is the main predictor of how it's going to go. Well, or one of the main ones. Um, the reason why I'm hesitant to say that there is something very specific with it is because there's the research, strangely enough, Miguel had physical therapists and chiropractors. He did the paper twice. He had people under imaging, dynamic imaging, and he told them to manipulate a segment and he observed which segments cavitated. So where there was the pop, so which segments cracked, right? And overwhelmingly, depends on the level, but it was like 2 to 3 segments would pop like almost every time. So people, the chiropractors who are raving, like the ones that really rave about traditional old school chiropractic, they'll always say like, "Oh yeah, but it's just because they didn't do the correct level or whatever, and you have to do it the very specific way to reduce the subluxation." Well, it's like well, you can't be that precise. So if you actually believe in that theory, it means that like more than the majority of people, you're actually putting it in the wrong space. If that makes sense, you're making the
Hmm.
subluxation worse because it's not you can't be that precise. That's number one. And people are going to say they were not experienced chiropractors. They were, and they were experienced physiotherapists. That's not a good. I think they had like at least 6 years of experience.
Hmm.
Um, so yeah, there's that. So that theory, that's just. I mean, if you're a chiropractor and you still believe in that theory, I mean, get with the program. It's like honestly flat earth level science. And Greg Kotchuk, which is like a really prominent chiropractor, did some research. And when you look at popping a joint and then you look at after, yes, the joint will move, but it'll go back to its initial position. So we know something happens, and I'm sure it can have, for a lot of people, it can have like a relieving effect. Maybe like the nerve is pressed on by like a bubble of air. I have no clue. But the point is, like for the mechanism that it's like you have to be very precise is not in line with research. And NIM 2020 did a paper on this. Like the level at which you do the manipulation doesn't seem to impact the outcome. So you could have neck pain and do it at the thoracic spine. You get the same results that if you do it very, very specifically. There's other papers where you look at um, like a level picked at random versus the one that the chiropractor selected very specifically. And there's also no difference in terms of outcomes. So the point is, again, it's like I don't believe there's something magic about it. I think there might be something magic about humans. Like the human touch is very useful, right? And we see a lot of manual therapy papers where even just touching feels good. I do believe that there's maybe like a very, very small segment of the population where they do get a big benefit, but they're mostly outliers. Um, so yeah, it's like I believe I know everything what's going on that chiropractor can never help. I no, I just think just if the only treatment you're getting is spinal manipulation, in most cases, it might not be the best investment of money, especially if they're like you should come back every week to kind of get that. If they talk about subluxation, my advice is always probably you should walk out, right? If they're like your
Mm-hmm.
spine is out, that's a sign that they haven't read or they don't believe in modern science, I think. But again, it doesn't mean that it can't help. It's just for the majority of people, statistically, not the best guess. But there's some very good chiropractors, like one of my colleagues. Like I have a company and he works with me, Elliot Sierra. He's like the Rehab Chiro on Instagram. Probably the best clinician I know. And he's a chiropractor. There's amazing ones that I follow and who follow me. Um, but again, it's just if you're talking about traditional chiropractic, that's like kind of a different situation. That those are more like modern chiropractors. Yeah.
Yeah. Yeah. And I mean, there's definitely been a drastic different experience that I've had with traditional chiropractic versus what I would consider more modern chiropractic. You know, yeah, I really can't sing any praises for the traditional approach. And I I'm out of my element here, but I remember um one of the docs that I was working with at one point in time, they were working on a paper, and what they were looking at is that, the benefits wasn't because of, subluxations, but actually the mobilization of the spine was releasing some sort of stagnation, right? So it was actually more of a biochemical change that was happening. It was basically, if I remember right, it's something about actually helping move ions through the spinal fluid, or what, like pockets of stagnation, and that spinal manipulations and stuff like that were a way of kind of like opening that up, but it wasn't actually the physical moving of the bones that was causing any of the benefit. Like I said,
Yeah.
I'm out of my realm there, and it's been a while since that conversation, but I was like, okay, that's an interesting look. Um, and this was from a doc that didn't do much for spinal, like, manipulation, period, like
Yeah.
in terms of his practice, but more so other stuff, But like, I don't know, the most extreme case I think I had is I went like a couple years with unresolved shoulder pain, and I saw a whole bunch of people, and I just, basically incline pressing on my right side was just not an option. And then I went to a guy that did Atlas orthogonal, which is basically a specialized way of, um, you can call it manipulating the atlas. They use a little, it's it's like a machine version of an activator. I'm sure you're familiar with what an
Yeah.
activator
Yeah.
is, right? But like, it's done in a precise way. Immediately after that, pain gone, and like a substantial, like 65-pound increase in my bench press like the following day, and then that sustained. So I was like, okay, that was pretty cool. And
Yeah.
I had tried a whole bunch of things, so I don't know why, if anything, I would have believed that would have worked more than any of the other things that I tried. So that's, for me, that's just an interesting one because I have trouble looking at my anecdotal experience relative to the science. But also I would say is that I like, I do not see that as traditional chiropractic, or by any means like what the normal or average experience that people would
Yeah.
get. Anyway, moving on from my anecdote in chiropractic, I was just curious there. So let's talk about then return to play for athletes and whatnot, right? Like, what are you looking at from progressing them, other than just like, okay, getting them out of pain, what are the things that you're kind of implementing in terms of, is there a certain checklist that you like to have accomplished before we go back to loading? Are we just using pain and discomfort as the scale there? And are you trying to reinstill, or are you trying to have them do things that are going to reduce the likelihood that they end back into the pain position?
Are you talking about just like patients in general or low back pain patients?
Low back pain.
Yeah, I'd say it's very individualized. And with my patients, I try to have them lifting consistently the whole time if they can. So I'll try to add stuff back from their program. So usually I work with a lot of trainers. The way I do is I'm like, okay, we're cutting this, this, and this, and replacing it with this, this, and that. So I try to keep volume the same, just redistribute it or adapt it where I can. And then basically when I judge that my job is done is when basically pain is minimal and they're back to like close to where they're at. So I'll be like, okay, we'll just slowly ramp up back to your previous levels. Depends, obviously, if they always get injured at a specific range, like, oh, I always get injured when I hit 250 kilograms or whatever. But like, okay, maybe we'll supervise you closer. But for most people, I'll get people that are close to their prep and they're like, I need to make this comp. Like, can you like help me or whatever? And I'll do my best there. So I'll get them back to their when they're close to their PR, basically, I'm pretty much done with them. And hopefully, like part of my approach, like it's mostly education. So they'll kind of know how to take care of it in the future, hopefully, when I'm done. Um, but yeah, so I wouldn't say I have like guidelines per se. There are some exceptions, but it's mostly for people who don't lift. Like I'll use there's some measures. There's like the Berglund test, I think it's called, the Beering Sorensen test. It's like a muscle endurance test, but like most athlete will pass that quite easily. I use that to know if they're viable for doing deadlifts, if that's something they're interested in. But I've never seen a powerlifter not pass it, so I don't. Again, for athletes, it's not that relevant. But the point is, it's like the hurdles or the things I'm looking for, the criteria for return, they're basically my rehab. So no, they're not specific. It's basically getting them back to what they were doing before, and with the benefit of the education that I provide the whole way. And then I'll be like, yo, if your back feels sore, this is what you're gonna do. You can switch to this one and kind of like teach them load management, if that makes sense. If your back feels sore, maybe you switch to a heel lift squat, just, for a few days until it gets better, so you don't lose your volume, but you can still, you're not going to flare up your back. But it depends because again, there's some people where their back is really intolerant to extension. There's some people where their back flexion is really intolerant, not poorly tolerated. So it really depends what type of patient I'm dealing with. But again, it's like it's in the doing, if that makes sense. I don't have like a specific criteria. It's dependent on the patient.
Okay. Do
Yeah.
you, so if a person gets injured, they come to you, you get them back out of pain.
Yep.
Are you most of the time being like, hey, if you're fine, feel fine doing the routine you were before, the way you were doing it before, just go back in and continue? Or would you like to see, since the previous approach ended up with them in pain at
Yep.
one point in time, are you trying to say, hey, maybe you would benefit if we do go through greater ranges of motion, but just maybe not in your, performance lifts or something? Are we adding accessories or anything like that as a kind of a preventative or an addition to their program to try and be kind of like proactive to?
Yeah, that's a good question. So, as we mentioned earlier, like human movement is so stochastic that it really depends. But if it's like a really recurrent thing, it's like every time I do these, my back feels like shit. And it's especially if it's not something that's relevant to their sport, I will cut them, right? I'll be like, how do you feel about these? But if it's like it's deadlifts and they need to do it because they're powerlifters, obviously I'm not going to cut it. It's just I'll maybe adjust like, hey, maybe you're not a person who needs to be doing deadlifts 3 times a week. Maybe we can cut it to once or twice, let your back recuperate. Because the way I like to treat like imaging and a lot, and that's one of my favorite things to do is like analyze imaging and kind of breaking down for patients because doctors either don't have the experience or they don't have time. And I don't mean like reading the imaging, just reading the report because I read a lot of research on like how is this useful prognostically. Well, the way I explain their changes a lot of the time is like this is like hypertension. Like it doesn't mean you're gonna have a heart attack. You just might have to be more careful because your risk increases. So like let's say you have degeneration. A lot of people will cite the Bring paper from 2015. It's a meta-analysis looking at people with no pain. And they showed that almost everyone has disc degeneration. So it's basically if you're 30, you have 50% chance of having disc degeneration. If you're 40, if you're 50, it's like 70%. So it's basically the decade of your age plus 20%, roughly. It's like a rough estimate, basically. But if you're 70, it's almost impossible not to have disc degeneration. People will cite this and say this doesn't matter. It's a big mistake because if you read the other review, Bring did the same year, disc degeneration, there's a 7.54 odds ratio of having pain if you have it compared to someone who doesn't. But again, if everyone has it, the way I explain it is like, yeah, it's a risk factor. Like your findings are risk factors, but they're not like a life sentence. So just think of it like if I have people who have a lot of changes, and I rarely like use the MRI per se to kind of make that decision, but I'll use it if I have the MRI and it's someone that keeps getting injured, is like, it's something you have to maybe take care of. Maybe someone, it's kind of like someone who has a history of obesity. You're gonna be like, yeah, maybe that guy can like drink Coke every day and be fine and have like a six pack, but you don't, right? So you need to take more care of it. Maybe you need to exercise more. Well, the pendulum of that would be like, hey, maybe your back is just more sensitive. There's some people that have a more sensitive back, and maybe you need to shift, like, pay more attention to your loading, and maybe avoid these or that exercise. It's highly dependent on the patient, but I'll say history is a big one. And then there's also people where I do like goal reorientation. Like, let's say someone's goal is just to live healthily, and they're not like a powerlifter. They don't give a shit. They're just, I go to the gym to feel good, and or I go to the gym to lose weight. Everyone has different objectives, right? But sometimes they get pigeonholed in this training program that's like, oh, this is like, why do you have a bodybuilding split? Uh, when you just literally just want to be healthy, you don't give a shit about muscles. Um, I'll just give one that feels good. Like, why would I choose the option that keeps re-injuring them if I don't need to? But like if it's an old person, I might make them deadlift a lot because like what they're struggling with is getting their grocery up the stairs. So like it's highly I'll say yeah. So again, a long-winded answer. I reorient the goals so that they fit the person's objectives, and I base a lot of that decision on the history for athletes specifically. Because again, that's the main predictor of future injury is having an injury in that spot before. Um, so yeah, I guess that's kind of how I would explain it.
Mhm.
Yeah.
And I know this is probably going to be a very individualized and it depends answer, but
Yeah.
I'm going to ask the question anyway because
Sure.
people love these type of questions. Um, in terms of range of motion versus loading, right?
Yeah.
Do you see one having more utility than the other, or is there a order in place in which you try and expose somebody to a greater range before loading, or do you try and expose them to loading in a limited range first, or do you find there to be any pro or con to either approach? Because it seems like a lot of times there's two camps. There's the people of like, oh, okay, we're going to give you a whole bunch of low intensity drills and exercises. And then there's the camp of like, oh, well, we're just going to keep doing the same activities, but we're just going to reduce the loading and use load management and work our way back up.
That's a tough one. So do I cut load or do I cut range of motion? Um, it depends on my population. If I have like strength athletes, I'm a big fan of cutting range because like if you look at a lot of research, I'm not too familiar. I forgot. Maybe you know the paper, but it's the one where they compare deep squats to 90-degree squats and
Oh,
hypertrophy
the
for
Kubo paper.
Kuber, yeah, Kubo 2015, I think. Yeah, they if or 2020, I don't remember. But point is, for most muscles, the hypertrophy was quite similar, right? I believe it was the glutes that got bigger if
The
you
the
went deeper.
quads were similar, but the glutes and I believe the adductors were both better with the deeper squat.
Yeah, so the way I'd explain it to a lot of people is just, okay, we're gonna split your squat in two. So we're gonna do a 90-degree squat because a lot of people they'll be able to tolerate almost full load because they have that buffer where they're not going to full flexion. So it's still tolerable with very heavy loads. So they maintain their quads that way. And I'll give them maybe like a hip thrust, which is way more comfortable for their back, or some other variation. And then maybe something for the adductors, right? So I split it in three. So their volume for the muscles look the same. Obviously, they're not squatting as deep. It's a less time efficient way, but the way I explain it, it's like, okay, this is your rehab exercise, is that extra exercise. So they can basically maintain the volume, but without the pain. So that's for strength athletes. Um, for people that are not strength athletes, where it's just about getting back to it and like reducing pain. I honestly won't use weights for a lot of them. Like most patients, I just do the exercise that's most likely to be done because again, doing the exercise with confidence seems to be a big predictor of like if people are going to do better based on that huge network meta-analysis by Hayden. So I just give them stuff that requires no equipment and gives movement. If they're like a ballerina, I do something that looks like ballet or something. So it's encouraging. They feel like they're going through the motions to get back to the mountaintop that we're at. But the reality is, like, a lot of people are sedentary and they're office workers. They need something they can do, like, with no equipment, get off their chair. They're like, okay, you got your movement break, do this. You got a little movement snack. So yeah, for them, it's not necessarily looking at range or load, but I'll say I'll probably cut load because I'm not using load for a lot of them. Yeah,
Mhm.
yeah,
So since you kind of brought up like using exercise selection, you know, as a way around it, you work with mostly power lifters, but I would say on average, most of our following, are coaches that coach people in some sort of physique, whether it be general population looking to lose body fat or people looking to
yeah,
build muscle. And there's a lot of utilization of machines, hack squats,
yeah,
pendulum squats, leg presses, and stuff like that. And obviously, so we have a lot of options to reducing loading spinal flexion. But that doesn't necessarily mean that we're alleviating all of the torque on the low back and stuff like, especially if you're doing like deep leg presses and stuff like that.
yeah.
So do you have any insights or pearls in terms of like, even if you just take your powerlifting population in terms of like, are there specific machines that you find you have been able to utilize more or of avoided?
Yeah, I'm a huge fan of like the recline knee extension machine, like the really old one. You know what I'm talking about?
Where you can be in hip extension?
Yeah, yeah, yeah. The one
Okay.
I believe it's more stress on the is it the rectus that crosses the joint?
Yes.
Yeah. I use that a lot already for ACLs because it's really important to have a strong quads for ACLs. So I'm a big fan for that one because again, if there's no variation of the squat that hurts, I'll use that one. But also because a lot of people with low back pain, they'll have tension in that structure called the neuromeningeal sheet, right? So bringing the leg up is almost it's the way we test tension in the nerve. It's not 100% reliable. The point is, a lot of people with low back pain, if you have them sitting straight and lift their leg up, it's going to feel horrible. If you make them recline, they're able to go way further. So they'll be able to get a really good quad stimulus, arguably better than the straight uh just knee extension one. But there's going to be less stress on that nerve that often gets irritated with people with low back pain. So I love that one. And then the adduction machine, because again, that's a good workout for muscles that are kind of undertrained already for the legs. But your spine is basically static. Huge fan of that one. And when I'm late stage, again, we mentioned erector spinal strength might have an influence on recurrence of low back pain, like a small effect based on like limited data. I'm a big fan of like the hyperextension ones, like the
Mhm.
45-degree machine, or you can do it with I always miss it's different in French. It's like the GHR, I think. The
Yeah,
one
the
where
glute
you're
ham.
yeah, glute ham race. Like the back extensions, I'm a huge fan of those ones. If people want like preventative exercise, I'm like, well, we don't really know what, but if I have to take an educated guess, that's the one where I'd go. And I'm saying educated guess, someone's gonna catch a stray bullet. A lot of things I don't like about social media and the influencer, they'll be like, this is the best exercise for this. I was like, for me, I don't know. I try to be more
Mhm.
honest if I can. Yeah.
What are your thoughts on hip flexion? Because I see that as also one of the most undertrained motions with lifters is hip flexion.
Yeah.
So that's been kind of one of my things that I've thrown in, especially for people that have ended up having chronic back stuff, is,
Hmm.
in addition to like I think adduction and abduction definitely fit on there,
Yeah.
but obliques and hip flexion are the other two that are kind of at the top of my list in terms of like bringing up muscles that I think help with stability there that are very undertrained or underrepresented in people's programming.
Yeah. I mean, if it's relevant for their training, let's say I have a sprinter with low back pain, I'll definitely like include that just because it's like useful for their training, and I think it's going to help for low back pain. I do think it's going to help for reduction of pain because again, I think any movement done tolerably is going to be helpful. but I don't think it has like specific protective effect, if that makes sense. Unless it's something they do a lot and then maybe they compensate with their back when they're doing a lot of like hip flexion movement. I just don't have a sport in mind that would do that. Maybe calisthenics.
Yeah.
Um, because again, I'm not saying that's what you're doing, but a lot of people what they'll do is they'll say like, oh, the psoas is like the main muscle involved in low back pain because you get that lower cross syndrome or whatever. And it's like they'll say your hip flexor is not tight, it's weak, so you need to strengthen it. Um, yeah, but I'd say that's based on like Vladimir Janda theories. And the main papers we have on this, we have like two. We have the Elsing paper from 1988, and what it showed is that there's no difference in terms of range of the hip flexor or the hamstrings in people with low back pain or people that will develop low back pain. And that was like a fairly large study. And if we look at it in or more modern understandings of biomechanics, it doesn't seem to fit either. So my point is like if you want to give it for low back pain and people like it, yeah, I'm sure it's going to help, but I wouldn't. It would be my go-to for prevention if that makes sense, because it doesn't seem like a weak or tight psoas is a cause of low back pain. It's probably more of a symptom, right? One really easy way, and it's probably not the best way, but it's the way people are going to understand it the best, is like let's say you have low back pain, extending your spine is going to hurt a lot, right?
Mhm.
If you do that a lot, your body's just going to be, okay, I'm going to make his hip flexor tight because I want him, because you're always like contracting that muscle to prevent that movement.
Mhm.
So it can be like protective stiffness, right? So that's why I think the association is misconstrued a lot. Same reason for hamstrings. Like, yeah, your hamstrings are tight. It's like, yes, because you have low back pain, your back, doesn't want to bend right now. It's healing, it's desensitizing itself. So again, great exercise probably for treatment of low back pain. For prevention, I'm not too convinced. Yeah.
How much of a limitation do you think it is when, in this field, when we're looking at the difference between, we'll say, trained and untrained subjects? Like, that's usually a thing that's thrown out. And actually, Meadow just posted a thing today on
Yeah.
it. And I think, like, like in the hypertrophy realm, a lot of times it's just I don't agree with the results of this, so I'm just going to complain that it's untrained subjects or whatnot. Not that
Yeah.
there's zero merits to it. But if anything, I would lean towards like something like that of actually there probably being a bigger difference between the more sedentary population and the athletic population in terms of I mean, because it's like in one population, it's movement and loading that likely got us there. And then in the other population, it's the absence of movement and loading that's getting
Yeah.
there. So essentially, it's like we're getting to pain via two very different mechanisms. And
Yeah.
I'm wondering how representative the studies are where most, if not all, are relatively untrained, how well that correlates to that. Because I mean, what's the average hip flexion, of a power lifter? It's like probably, I it's going to be representative of not the healthiest untrained people. Like that's kind of one of the things that I see is sometimes it's like the most extreme on the, physique or strength sports end up representing similar physiology
Yeah.
to the worst health sedentary people. And that extends from both like range of motion all the way even to like blood work.
Yeah. That's honestly, I haven't thought about it that much, but yeah, the way I could say is a lot of like if we're talking about specifically strength, most of the measures that we have are based on they're always athletes in there. Like all the most readily available data is people with strength, and I think that's good because it's more useful for them, right? Strength is more relevant if you do a sport because you need a lot of strength to express power. In the sedentary population, we do have a lot of research because it's really easy to have someone mostly sedentary, like a lot of people are, right? But that's going to be mostly with pain. So it depends. If you're talking like mostly injury prevention, almost most of the data is going to be on very active people. Because the first reason is easy is just because it's easier to power a study because athletes, like the main predictor of injury, one of the main ones is participating in high level sports, right? So it's like if you take 1,000 people and none of them get an ankle sprain because they're sedentary, that's it's gonna suck. It's a big waste of money. Um, so I'll say one limitation would be like I don't know how useful it will be sometimes for certain things to get someone stronger for the prevention of injury because it's like how often are they exposed to it? But I will say that if I look at data in other ways, like again, if we look at, for example, ACLs and other stuff like shoulders, if we look at the tendency, it seems to be that like if people like the people that are the weakest are going to benefit the most from the intervention. So the one way we see that is one of the big reasons why we think women get way more ACLs. I think it's like 2 to 4 times more than males, is because there's not that. First of all, they have less testosterone, so they're less likely to get stronger quickly, right? So the less muscle mass, and also they're less encouraged to go in the gym and work out and stuff like that. But the pendulum to that is that they're the ones that benefit by far the most from injury prevention programs for the ACLs. And it's probably because it's low hanging fruit. I'm not like shitting on women, it's like a cultural thing. And I'd say that if anything, that should make us advocate for more women to be in the gym because it's probably going to be healthy for them, especially if they want to participate in sports. We see the same for like elderly people. Like they seem to have a lot of benefits from strength training compared to, probably like someone like you and I, probably you less because you're already doing it. You know what I mean? So I would say, yeah, while the research is limited, whenever we test like people that are not super, that are more naive, I'd say to the gym, they tend to respond better because they get these newbie gains and they probably get a lot of the benefits, or even they like reverse some of the stuff that they get from being sedentary.
Hmm.
Right. So overweight people, just from being a little bit active, even like brisk walking, there gets like very good benefits at almost every health measurements. I like even if you remove the weight loss, or they don't achieve weight loss, just because it's like exercise is generally helpful for micro inflammation.
Hmm.
So yeah, I don't know if I answered your question, but yeah, that's kind of my take.
So the last question I'll ask
Mhm.
on this line of like, trained versus untrained. My anecdote experience like has
Yeah.
been that more trained individuals, there ends up being something specific that seems to make a difference.
Yeah.
And the less trained, it's just almost anything helps and just all general things help. But like
Yeah.
the more trained, the more it seems like one particular exercise or motion seems to have a drastic effect.
Oh yeah.
Whereas like, like and everything else could be nothing. Whereas people that aren't trained, they could do a variety of things and they all seem to be equally kind of beneficial.
Yeah, I agree that, I mean, that goes back to the low hanging fruit thing. It's like, the athletes is you need to be precise because they're already doing most of the thing they should be doing. There's exceptions, like sometimes their diet is shit because especially for women, because they have pressure to be thin, but also pressure to be athletic. So they'll be like in, bone deficient diets, or have like the symptoms of RED-S, like that make them at risk of like wrist fractures. But in general, yeah, the athletes do the small things well. The general population does not. They don't do the basics. So yes, yeah, I agree. Before we go, there's like one thing we didn't talk about, and it's like the effect of like repeated movements on discs, because that's one
Mhm.
thing I have against the using cadavers to extrapolate to humans. Yeah. If you want to edit it, it's probably going to fit better at the beginning. But one thing, again, the flexion is really vilified because they'll say that it pushes the disc in the back. And it's true that if you look at papers, like Hani had a paper on this from 2009. It's like a review of all the studies that look at disc migration in response to certain movements, like flexion, extension, lateral flexion. And yeah, it's true. Like almost all the papers, if you look at healthy discs, the disc will move back when you flex, right? Because that's how the fluid shifts, right? If you go to an extension, the opposite happens. It's like 9 out of 11 or 10 out of 11 for both directions. The problem with that is twofold. So first of all is that if you look at unhealthy discs, they don't respond predictably, right? So 4 out of 8, I think, of the papers in that review showed that like if there's degeneration, we can't really predict where the disc is going to go. Um, so yeah, Ed Munston had similar findings in another paper. So point is, it's like, yeah, it only works if you have a healthy disc. And the problem with that is, again, as I mentioned earlier, the Brinjigji paper, the review showed that like disc degeneration is so prevalent. Like if you have someone that's 50, it's like 70% risk of degeneration is someone that does not have pain. If you look at someone that has pain, it's 7.5 times more likely that they have disc degeneration. So basically, that data is basically unusable unless you're like convinced that that patient has healthy disc, which is if he's coming to see you, is rather unlikely. I'll say the model, like the big caveat is basically once they're past 50, that model is completely useless. When they're younger, maybe. But the big problem with this is that this is mostly for static positions. So like if you go an extension and stay there, or flex and stay there, it doesn't reflect the behavior of the disc exposed to repetitive movements. right? Because if you go in extension, yeah, you compress the disc in one direction. That's how the disc move. The vertebrae compress it. But if you come back to neutral, it just the water just comes back. And we know this from a paper from Abdullah in 2018. Basically, it was looking at the McKenzie approach that I mentioned earlier. The way we believed it worked was by shifting the disc back in place. We thought that's how it worked. But that paper showed that like if we do those repeated movements, the disc doesn't do that. It barely moves. It comes back to its place after. We see that in papers on running and lifting. Once you lift, during the day your disc gets smaller, but when you wake up, it comes back to baseline. So the point is, those animal models, they kind of forget the whole point that humans adapt. And maybe if like on imaging, yeah, or repeated movements where literally there's no blood flow, yeah, the disc is going to break if you do 84,000 repetitions or 20,000 repetitions. But humans adapt, and if we didn't, we probably would have even more low back pain than what we do because low back pain is really prevalent. But yeah, the point is, it's like it's not that usable, and the idea that like flexion is always bad because it shifts the disc in the wrong direction is, I think, kind of ignorant because it doesn't pan out in humans, if that makes sense, or not predictably.
Yeah.
Yeah.
And if we didn't have the shift, we wouldn't have the mobility anyway, right?
Yeah. Exactly.
Yeah.
Yeah.
I think the most important takeaway there is for all of you short kings out there is to take girls out for coffee instead of dinner because you'll be just a little bit taller in the morning.
Yeah. I believe there's like a 4 millimeter difference after like a 6 kilometer walk. So yeah, maybe
Yeah.
useful for the NBA combined though. If any
Yeah.
future NBAs are doing it, sit before you hydrate your disc. So before they do the height measurement, and literally just stand up right before the measurement, and then sit back down right away before after they do it with shoes.
Mm-hmm.
That'll be $1 million when you make the NBA draft, buddy.
Okay. Let's have this be the last one, and then
Yeah,
I'll let
sure.
you go because I want to be respectful for your time. But uh, on a similar principle, since we're talking a little bit about fluid dynamics here in the disc,
Yeah.
um, let's expand that out to the concept of bracing and where and how you think that takes or plays a role in terms of helping with the low back stability, right? And maybe your thoughts
Oh,
on
bracing.
utilization of belts and stuff like that, and whether or not should all of your training be with the belts, or should you be intentionally trying to do as much of your training without the belt and relying on your own musculature, etc. And if you have any, preferred techniques in terms of bracing, I'll let you kind of. I am. I prefer that I get my athletes to do as much loading and stuff without the need of a belt.
Hmm.
One, so that they're just kind of training all of the musculature naturally. But I also like when I'm looking at modeling that, I think the impact of the bracing in terms of how much stability it actually gives us is extremely overrated. But
Yeah.
I'm curious what your thoughts are on
Yeah. Yeah, so that's a good one where I think having a great opinion is a good one because my friend Elliot, the Cairo I mentioned earlier, the Rehab Cairo, and also Aaron Kubal both did reviews on this. And it's basically there's no research that shows that it improves stability, but anecdote, like people that use belt will always say like I can lift more when I use the belt, and I feel more comfortable. If we look at guidelines for low back pain, it is not recommended to advocate for a belt because we haven't seen no use and it costs money. So if people have one, I'm like, yeah, sure, use it if you want to. But if they want, like, should I buy one? Except if they're a powerlifter. I talk like those for comfort. I'm like, yeah, you should not buy one. It's probably a waste of money. But if you're a lifter, yeah, I'd probably do the same as you. Like you use it for your rep max because it's gonna make you lift more. Why? Honestly, we don't really know why. It might be because you have something to press against, like proprioception. But yeah, I don't think it's gonna stabilize your spine because if it's biomechanically, if it were pushing against, the belt, your spine would already be out, if if that makes sense. And yeah, I'll say honestly, we don't really, from what I gather from the literature, we don't really know how they work, but they do seem to help you lift more. Um, but again, if they help you lift more, you want to be able to replicate it. So again, like you mentioned, I think it's a good strategy to keep it just for the rep max because that's when you want to lift the most, but you don't want to be always repping more than you can on a repeated basis, if that makes sense. Yeah, so I think
that.
it's a good strategy. That's what I advocate as well.
Yeah, and I think one of the observations I've seen is that The belt seems to be have a larger effect on people who have had a back issue in the
Yeah.
past or
Yeah.
currently have some sort of discomfort. And
Yes.
so I don't know if that raises the placebo or just simply the physical contact or, whatnot gives them some proprioceptive security, with that as well. And I can say that even from my own experience. Like
Yeah.
I it's I'm not a power lifter and, you know, so I don't see the need to do a lot of sets where I feel like I would need to
Hmm.
use a belt, but like in the few instances where like my low back has felt a little dodgy, I'll still be like, I'm gonna throw the belt on here just in case. And it's like, oh, it does seem to help a little bit, but it doesn't seem to do anything in terms of like, oh, it's not like wearing the belt for a while made my back feel better or anything. Just the experience of that lift seemed to go be a little bit better, right? And who
Yeah.
knows, maybe it's just the fact that that compression just makes us feel because we feel more rigid. We feel like
Yeah.
we're a little bit more
I've,
secure, but we might still be
yeah.
getting the same degrees of flexion in there. We just experience an overall tighter feel while we're doing it.
Yeah. I will say there's some claims that it makes the abs weaker, and the papers on this, I believe there's like one. It should doesn't mirror those findings. So it's like I don't think it makes the abs weaker if you wear it. I just wouldn't wear it all the time because it's probably a waste of time. And yeah, I believe like the thing that you mentioned, like the comfort, I believe is a big aspect of it. There's, a lot of people will say knee sleeves are useful. If we look at it from preventing pain, they don't do much, but they do increase comfort, right? That's something that's actually documented in the research, and a lot of people will say, yeah, sleeves help me lift a little bit more at the knee. So I would just say they're kind of sleeves at the back, if that makes sense.
Mhm.
How do they work? I don't know, but if it makes you lift more, just go ahead. Yeah,
Awesome. Awesome. Well, I think there's almost 2 hours there. So
yeah,
hopefully people picked up some things on the low back there. Is there any of like final takeaways that you would want to suggest for anybody that jumped on this because like, oh, low back and I'm currently experiencing some issues in terms of just like, hey, here's my suggestions. You already kind of gave like if you have red flags, go
yeah.
see anybody, knowing that this population is pretty much purely a lifting population.
Yeah. If you do want to go see a chiropractor, I recommend not the nice guidelines, the Choose Wisely guidelines. It's a way to kind of rule out the absolute quacks. It's like no repeat x-rays. I recommend just it's not only spinal manipulation, stuff like that to kind of help you choose a good one. And if you want to see what general management, like very general management, looks like, the nice guidelines from the UK are still pretty good. They even list their evidence, so I would say that. In terms of any outside of the stuff I said, I'd say beyond that, it's kind of like too specific. No, and if you need a consult, I guess you can just check my page. No bullshit
Awesome.
physio.
Well,
Yeah.
speaking of your page, yeah, where can people find you? Because you have a YouTube, right? As
I
well.
have a YouTube where I upload like longer videos, with like more content. There's like a lot coming. Instagram's the one where I'm most active, and then I'm also on Twitter, but Twitter's mostly discussing with like PhDs and other nerds about recent papers that came out. So it depends what you're into. If you like a mix of education and memes, probably Instagram, and YouTube for like more serious stuff, I'd say.
If you enjoyed this episode, make sure you give us a like, subscribe, and leave us a review, and we will see you on the next episode of the N1 Experience.